presentation. If during the course of the presentation you have a question, you can put it in the chat box, or you can just leave it till the end and raise up your electronic hand, and it will be acknowledged and you'll be allowed to make your comment. So to reiterate again, my name is Dr. John Afam, the trainee representative of the NSA and the moderator for this session. This session is Anesthesia for Laparoscopic Surgeries, to be delivered by Dr. Bridget Basi Ukeje. Dr. Ukeje, you have the floor.
Good evening, my trainers and colleagues. Today I'll be taking anesthesia for laparoscopic surgeries. I will be looking at it this evening with the following headings. We'll look at an introduction, history of laparoscopic surgery, indications, contraindications, procedure for pneumoperitoneum, gases used for insufflation, patient's positioning, and the pathophysiological changes due to this positioning and pneumoperitoneum. Then we'll also talk about the anesthetic management for laparoscopic surgery, and we'll conclude. So by way of introduction, laparoscopic surgery is also known as minimal access surgery or keyhole surgery, and it has actually gained worldwide acceptance because of minimal trauma, lesser costs, its cost effectiveness, and shorter hospital stay. It was initially confined to majorly gynecological procedures for diagnostic and therapeutic purposes, but now it has extended to include other subspecialties. Then for the brief history, in 1901, Dr. Kellogg was the first to inspect the viscera of a dog whose abdomen has been supplemented with air. Then in 1910, Jacobius applied this technique to humans and termed it laparoscopy. In 1968, SEM discovered carbon dioxide insufflation. Then in 1970, laparoscopy was done for gynecological procedures. Then in 1989, Reddick and Oslin introduced laparoscopy for cholecystectomy. The indications of laparoscopy, we'll be looking at it at the various subspecialties that use laparoscopic surgeries. For general surgery, the procedures that are amenable to laparoscopic surgery are gastrectomy, colectomy, cholecystectomy, appendectomy, hepatectomy, to name only but a few. Then thoracoscopic procedures like lobectomy, pneumonectomy could be done under laparoscopic surgery. Then for gynecological procedures such as diagnostic procedures for like laparoscopy and dye test, which is a gold standard for tubal patency, it can be done laparoscopically. Also tubectomy, ovarian cystectomy, hysterectomy, and even the diagnosis of ectopic pregnancy. All these can also be done under laparoscopy. Then another thing is we have other subspecialties too, but those ones are basically endoscopic surgery. But because our discussion is basically on laparoscopic surgery, that's why we are looking at basically the ones I've mentioned. Then we have advantages. Why the advantages of laparoscopic surgery? Why is the world tending towards laparoscopic surgery these days? The first on the list is that there's a shorter hospital stay and early ambulation because of minimal scarring and minimal incision, lesser tissue handling. So it also has better cosmesis. Then it also has minimal tissue trauma, lesser post-operative pain, stemming from the fact that the incision is minimal and the tissue handling is also minimal. Then another thing that it helps is that it reduces blood loss intraoperatively and also lower costs. In our environment, actually, laparoscopic surgeries are more expensive. But the way they are looking at the cost effectiveness here is the fact that for laparoscopic surgeries, basically some of them can be done as day-care surgeries and with minimal incision and shorter hospital stay. That's why they are talking about the lower cost. Then another advantage is that there's lower incidence of incisional hernia because we don't have large incisions with abdominal wall defects where you could have hernias coming out from post-operatively. Then for the disadvantages are that the space is the narrow two-dimensional visual field. It's not what you are opening and seeing. And also you need a longer duration of general anesthesia as opposed to the open laparotomy. Then more expertise and skill, and also a longer learning curve for the surgeon, because even after qualification, they might need to go and specialize and learn minimal access surgery. Then another disadvantage is the increased incidence of post-operative nausea and vomiting. That's even been shown that about 40 to 70% there's increase in post-operative nausea and vomiting with laparoscopic surgery compared to other surgeries. Another disadvantage is the fact that we have referred shoulder tip pain, which stems basically from the fact that nerve irritation, diaphragmatic irritation will bring about this from the gas, carbon dioxide that is being used. Then another drawback for this laparoscopic surgery is that there's difficulty in estimation of blood loss in this patient, as you cannot clearly see what is happening. Then we have contraindications to laparoscopic surgeries, and these contraindications will be absolute or relative. For the absolute contraindications, patients with refusal is top on the list. Then an inexperienced surgeon that doesn't have the skill for laparoscopy is also an absolute contraindication. Patients with bleeding disorders, because of the fact you cannot really estimate blood loss, are also contraindications to laparoscopic surgery. Patients with severe obstructive pulmonary disease are also is a contraindication to laparoscopic surgery, especially the one where you need to use CO2 or gas insufflation. Then history of recent myocardial infarction, as they can worsen it, is also a contraindication to the use of laparoscopic surgery. Then advanced pregnancies, because of the effects of increased intra-abdominal pressure and all. The cutoff for pregnancy basically is from 20 weeks of gestation. The ideal time for laparoscopic surgery in pregnancy is second trimester. First trimester, the risk of miscarriage is high, so it's generally not advocated for. But from the second trimester to like 20 weeks, you could do laparoscopic surgeries. Above that, because of the increasing abdominal size and increase in intra-abdominal pressure, laparoscopic surgery is actually contraindicated in these people. Then people that have increased intracranial pressure from any cause, the fact that you are using CO2 for insufflation can also increase the CO2 can cause cerebral hypercapnia, but could also cause cerebral vasodilation. So in people that have raised intracranial pressure, it will just worsen the increasing intracranial pressure. Then people with ventriculoperitoneal shunts, they are also contraindicated for laparoscopic surgeries. Then for the relative contraindications, we include massive ascites, abdominal scar, because of scarring, creating a pneumoperitoneum might be difficult, extensive organomegaly, hypovolemia, because with the pneumoperitoneum, there's reduced venous return and cardiovascular compromise. So people that are already having hypovolemia are relatively contraindicated for using laparoscopic surgeries. Then the last on the list is the large intra-abdominal tumors. The next is intra-abdominal pressure. The normal intra-abdominal pressure is about 6 millimeters of mercury. The intra-abdominal hypertension is defined as when intra-abdominal pressure is 12 millimeters of mercury or more. While abdominal compartment syndrome can be defined as an intra-abdominal pressure above 20 millimeters of mercury with evidence of organ dysfunction or failure. So when we have intra-abdominal pressure greater than 20, the ideal for laparoscopy is between 10 to less than 15. So some modern laparoscopic machines, once it's above 15, there's an audible alarm to alert the surgeon to reduce the pressure. So for this, above 20 millimeters of mercury, at this level, there will be reduced perfusion of organs and organ dysfunction, such as there will be hypoperfusion of the kidney, so you could have acute kidney injury as one of the complications of this abdominal compartment syndrome. Then also, because of the splinting of the diaphragm with the excessive pressure, you could also have respiratory compromise in these patients. Then also bowel ischemia could also be one of the complications from this. Then small changes in intra-abdominal pressure are usually tolerated, but as the pressure gets higher, it worsens the regional blood flow, as I've said earlier. So laparoscopy can be preceded by creation of pneumoperitoneum. The essence of creating this pneumoperitoneum is that's a medium by which the organs can be visualized by the surgeon. So for this laparoscopic surgery, before there's insufflation, the pneumoperitoneum needs to be you need to be sure that you're in a peritoneal cavity before you can insufflate the gas. And ideally, the ideal thing is before insufflation, the stomach should be decompressed with an NG tube. This is to reduce the risk of trauma with the trochlear needle. Then the bladder should also be catheterized. All these things to reduce the risk of injury during the trochlear insertion. Then for the procedure of laparoscopy, the procedure, we should know the various instruments. We have the Veress needle, we have the trocar, we have the laparoscope. So basically, the Veress needle is what creates the initial incision, while the trocar is inserted, and it's through the trocar that the laparoscope is actually inserted. There are also some ways to know that there is correct trocar insertion. The first, you could have the double click sound, where the first click is piercing the rectus sheath and the second click is piercing the peritoneum. Then another sign is the negative aspiration sign. When you don't aspirate blood or abdominal content, you know that you're actually in the peritoneal cavity. Then the third sign is the use of the hanging drop test. Then another sign to know that is actually better is the insufflation pressure test. Ideally, because the peritoneal cavity is a kind of negative pressure inside, if the trocar is not in the peritoneal cavity, insufflating, the pressure can go very, very high, higher than 15 millimeters of mercury. You'll be having a lot of resistance to the insufflation. So that is actually the most reliable test to know. Then after this too, another thing is after insufflating the gas, initially the gas is insufflated at the rate of 1 to 2 liters per minute. Then after insufflating the gas, the quadrant of the abdomen, they are percussed for even distribution. You have a tympanic percussion note because of the air that is in the peritoneal cavity. Then the gas flow after the initial insufflation is then reduced to about 200 to 300 mils per minute. This is actually to maintain an intra-abdominal pressure of about 14 to 15 millimeters of mercury. Then the Veress needle is removed and the cannula inserted through the same incision. When the trocar is removed, the laparoscope is then introduced, which will aid in the visualization of the abdominal structures. So the gases for laparoscopy, the ideal gas for insufflation should be colorless, physiologically inert, non-explosive in the presence of cautery and laser, and easily eliminated. But the truth is that there is no ideal gas for laparoscopy because some of these gases have one or two issues. So for carbon dioxide, why it's preferred is that it's odorless, it's non-toxic, it's not combustible, and it's also readily available. And the fact that it's actually more soluble in blood and air makes it the risk of gas embolism is lower as compared to using air for insufflation. Then it's also another advantage of carbon dioxide is that even if it's absorbed into the peritoneum, there is also it can be eliminated by the lungs, or also the buffer system can be buffered too by the blood. Then they also said the lethal dose of carbon dioxide is to embolize is 5 times that of air. The side effects of carbon dioxide toxicity you could have carbon dioxide insufflation could have shoulder tip pain if the gas is not complete, if the abdomen is not completely insufflated at the end of the surgery. You could also have cardiac arrhythmias and hypercapnia. Room air was originally used due to the blood gas solubility of nitrogen, which is 0.016. But it has been observed it frequently migrated to the neck, mediastinum, and some other cavities. And also the fact that it's not that soluble made it the risk of air embolism was also very high with it. And also the fact that there's delayed absorption and prolonged postoperative shoulder tip pain. This is what made room air not favorable for insufflation. Then oxygen is not used because it's very combustive, it supports combustion, it can cause gas embolism and also explosion with the use of diatemy. The nitrous oxide was commonly used in the 1970s, but it causes lesser irritation of the peritoneum. There was also reduced risk of arrhythmias, and it has a good blood gas solubility coefficient. The side effect is that for nitrous oxide, one of the side effects is that the increased incidence of postoperative nausea and vomiting that it has. And another side effect is that it causes swelling and expanding of gas in cavity. So it could also dilate the loops of the bowels and also increase the risk of injury during trocar insertion. Inert gases like helium, argon, and xenon have also been tried. They are actually non-inflammable and there's higher risk of embolism. But one of the drawbacks is that it's not safe. If gas embolism occurs, they are not that soluble, and apart from that, they are also expensive. Another thing is the gasless laparoscopy, the concept of gasless laparoscopy. This is basically mechanical bowel, abdominal wall retraction that is done by a retractor to expose the peritoneal contents. The advantage is that the effect of pneumoperitoneum is not there, so it avoids cardiopulmonary consequences of the rest intra-abdominal pressure and hypercapnia. And also, the renal and splenic perfusion is not altered because there's no pneumoperitoneum that you are creating in these patients. Then also the reduced incidence of post-site metastasis because they are not insufflating with gases. And also it's also recommended for patients with poor cardiopulmonary reserve as the effect of a pneumoperitoneum will not affect the already existing poor cardiovascular reserve. Then the main disadvantage of this gasless laparoscopy is that it can compromise surgical exposure and increases technical difficulty as the exposure is very poor. So there will be difficulty in doing the procedure as opposed to the one where gas is being used for insufflation. The next is patient positioning. Positioning for laparoscopic surgery depends basically on the type of surgery. We have various positions like lithotomy is there. We could have lithotomy position to the Lemberg or reverse to the Lemberg position. For the head down tilt, that is to the Lemberg position. It's used basically for pelvic surgeries and submesocholic surgery. But the head down position is not favorable for the respiratory system as it decreases the functional residual capacity further by splinting of the diaphragm and cephalad movement of the diaphragm. Then the head up position is basically for supramesocholic surgeries. We should also endeavor to check the position of the endotracheal tube after any change in position with head down tilts. Then movements of the endotracheal tube with the right main bronchioles due to cephalad movements of the carina. We could have endobronchial intubation as a consequence due to the cephalad displacements of the diaphragm. So, as I said earlier, Lemberg for urological procedure, then dosing lithotomy position for gynecological procedures. The head-up position is actually favorable for the respiratory system because it increases the functional residual capacity. It's used basically for upper gastrointestinal tract surgeries and biliary tract surgeries. Then the lateral decubitus position is used for thoracoscopy, nephrectomy, and adrenalectomy. Another key point to note is that tilting should be slow and progressive to avoid the sudden hemodynamic and respiratory changes that occur with sudden positioning. So we'll now look at the various systems, how the positioning and pneumoperitoneum affects the various organ systems in laparoscopic surgery. For the respiratory system, there's a decrease in vital capacity and functional residual capacity and even pulmonary compliance as a result of this positioning because of the cephalad displacement of the diaphragm. There's also an increase in the partial pressure of carbon dioxide because we are using mostly CO2 as the insufflation gas. There's also an increase in the intrathoracic pressure because of the cephalad displacement of the diaphragm too. Also increased airway pressure and normal or decreased partial pressure of oxygen. All these things together bring about increases the ventilation perfusion mismatch and could also lead to hypoxia and also increase the risk of barotrauma during intermittent positive pressure ventilation. These changes are actually common in the head down position as I said earlier. The head up position is actually favorable for respiration. And these changes also, as we've said earlier, the normal physiological changes can be worse in patients that already have reduced functional residual capacity, such as obese patients, elderly patients, and people that are already debilitated. So to restore the normal lung volumes and respiratory changes during laparoscopy, general anesthesia with controlled ventilation is actually preferred over regional because of this. Then for the cardiovascular changes, the intra-abdominal pressure of about 10 millimeters of mercury, there's a decrease in cardiac output because venous return is reduced because of the increase in intra-abdominal pressure. And there's also an increase in the arterial pressure and also an increase in the systemic vascular resistance and also the pulmonary vascular resistance. When the intra-abdominal pressure is up to 20 millimeters of mercury, as seen in the abdominal compartment syndrome, there's an increase in the renal vascular resistance because of this. There's a decrease in renal blood flow and glomerular filtration rates, and also a decrease in urine output because of hypoperfusion of the kidneys. There's also a decrease in mesenteric blood flow and also intestinal mucosal blood flow. The relationship between this hemodynamic depression and level of intra-abdominal pressure is influenced by one, the rate of CO2 insufflation. If the rate is at a very high rate, these changes can happen so abruptly. And if the rate of CO2 absorption, if the absorption rate is high, then it can also help to mitigate some of these effects. Then also the rate of the rise of the intra-abdominal pressure. Then we should also know that the combined effect of anesthesia, the patient's position like an enable position, and increase in the intra-abdominal pressure, all of this together reduces the cardiac output by about 50%. The mechanism of this reduced cardiac output is actually multifactorial, as we can see in the next slide. The mechanism one is because of the reduced the pneumoperitoneum, there's a decrease in the stroke volume and decrease in the cardiac output. Then another reason is hypoperfusion of the kidneys too. We could also have we also have increase in semivascular resistance. All these things together bring down the cardiac output. Then the effect of pneumoperitoneum is also summarized, as I said earlier. Yeah? There's a change in systemic vascular resistance, there's a change in the preload, increase in the afterload, and all these things together reduce the cardiac output. Then for the pulmonary system, there's an increase in the partial pressure of carbon dioxide and end-tidal CO2, and also displaced diaphragm. Then there's also a reflex increase in the vagal tone. This is also for cardiovascular changes. This is basically due to the stretching of the peritoneum, bringing about vagal stimulation. So this one will actually bring about an increase in vagal tone and bradyarrhythmias that we see. Then another thing is that the treatment for these bradyarrhythmias is to discontinue the insufflation, administer atropine, deepen anesthesia after stabilization of the heart rate. Then another thing is that these arrhythmias could also be due to increased partial pressure of CO2 during hallucin or spontaneous ventilation. So the anesthesia proper for laparoscopic surgery. The ideal anesthetic technique of choice is general anesthesia with controlled ventilation. This is because what favors general anesthesia is the effect of pneumoperitoneum that's compromising the lung mechanism. For controlled ventilation, you can actually manipulate this by, if there's a hypercapnia or anything, you can increase your respiratory rates or hyperventilate the patient to normocapnia. Another fact is that because of this increased intra-abdominal pressure, this patient is also a full stomach with risk of aspiration. So at least securing the airway with a cough tube can actually help this. Then why it's also favored is that it's also counteracts the hypercapnia due to mechanical impairment of ventilation, as this patient is being mechanically ventilated. Then there's also absorption of CO2 from the peritoneum. It also, another advantage of GA over regional is that it provides good muscle relaxation and optimal operating conditions. Then also the cough tube prevents aspiration, as I said earlier. GA with controlled ventilation is used in lung laparoscopic procedures. Then for patients with pre-existing respiratory or cardiac disease, and also in obese patients with impaired vital capacity, functional residual capacity, and compliance. So for these patients coming for laparoscopic surgery, the pre-op evaluation history will be taken from the patients, from the biodata, with emphasis on the extent of associated comorbidities that these patients might have. In patients with poor pulmonary reserve preoperatively, like people with chronic obstructive pulmonary disease, a pulmonary function test is also advisable. For this pulmonary function test, a spirometry is advisable. The forced vital capacity all over the forced expiratory volume in 1 minute ratio, less than 70, is suggestive of obstructive pulmonary disease. Then this ratio is either increased or normal in people with restrictive disease. Then we should also know that there are also some bedside tests that can be done, like the bedside mask blowing test or the breath holding test. For the breath holding test, a normal value that is acceptable for elective procedure is about 25%. Less than 15% is a contraindication to elective surgery, and this person has poor respiratory reserve, and this surgery will worsen the person's condition. So for these people that are very poor respiratory reserve, an open laparotomy is recommended so as to avoid the effects of pneumoperitoneum and all the effects they have on the respiratory system that are already compromised. Then for people with cardiac disease, there are some cardiac screening tools like the least cardiac index can be used. This least cardiac index basically there are 6 parameters. The first is the history of recent history of myocardial infarction is a score of 1. Then another index is people that have increased renal failure is another score of 1. People that are diabetic on insulin is another score of 1. Recent history of a stroke is another score of 1. Then recent history of a stroke is another score of 1. So there are about 6 indices. Anyone that has greater than or equals to 3 points is actually has a high risk of perioperative cardiovascular incidence. Then in renal failure patients, we optimize hemodynamics and avoid nephrotoxic drugs. Then you also check the cardiopulmonary reserve by using the breath holding test. The normal is about 25 seconds, as I said earlier. So after the history, the next should be physical examination, do a general examination of the patient, checking for pallor and checking for dehydration to know if the person is hypovolemic, checked for pedal edema and other things. Then a detailed area assessment to ascertain every management of the patient and preparing adequately. Then the cardiovascular system examination is also of great importance, and the respiratory system examination should be done for these patients. Then after the examination, the next is investigations. For investigations, full blood counts will be done, looking at the blood levels, the HB platelet of these patients, looking at white blood cell count to know if there's any ongoing infection, especially with an elective surgery. Then blood grouping and cross matching should also be done, and blood made available if there's need for it. Then another test is the arterial blood gas, pulse oximetry, and pulmonary function tests. All these tests actually identify those at risk of hypercapnia and acidosis. Then serum electrolytes, urea and creatinine to check the functionality of the kidney and also to check for if there are any electrolyte abnormalities. Urinalysis can also be done. We could pick glucosuria in the urine, even proteinuria to also offer the diagnosis of renal impairment too. Then the ECG should be done to look at if there are any arrhythmias or to look at evidence of myocardial ischemia in these patients. Then baseline pulmonary chest X-ray should be done to rule out active pulmonary disease in this patient. Having done your history, physical examination, and investigations, they plan for the patient to get an informed consent for surgery and anesthesia. And this patient should also be counseled on the choice of anesthesia. Then specific complications of the laparoscopic surgery should also be explained to the patient during the consent. Then post-operative, we should also tell the patient about the possibility of having post-operative referred pain on the shoulders, and also the possibility of conversion of this surgery to an open laparotomy. Then the patient will also be counseled on the fasting guidelines, which is 2 hours for left fluids, 4 and 6 hours for solid meals. Then for pre-medications, the patients can be given anxiolytics like midazolam, also antiemetics. At this surgery now, there's a risk of post-operative nausea and vomiting. You could also give ondansetron or promethazine antiemetics to help. Then antihistamines like ranitidine could also be given. Prokinetics could also be given to the patient. Analgesia could also be given to the patient. Then HOP could also be given to counter the vagal tone of bradyarrhythmia during the laparoscopic surgery. Then this clonidine and desmonitomidine can also be given to reduce, this one can be used to obtain laryngopressor response basically. Then the preoperative antibiotic prophylaxis for the surgery should also be given to the patients. Then DVT prophylaxis if the surgery is going to be prolonged. Then general anesthesia is actually the anesthetic. These surgeries are amenable to general anesthesia or regional, but general anesthesia is the preferred one because of what I explained earlier. During the general anesthesia, back mask ventilation should be minimized. This is to avoid gastric distension and the risk of injury during the tracheal insertion. This patient should be adequately pre-oxygenated. Then insertion of the NG tube should be done to deflate the stomach, as this will also improve surgical view and also avoid gastric injury during trocar insertion. Then the pressure response to laryngoscopy can also be obtained in this patient by using lidocaine at a dose of 1.5 milligram per kg. This should be given about 90 seconds prior to laryngoscopy. The induction agent of choice, propofol, is actually a very good introduction agent of choice. The advantages is that one, it's the rapid, it has a rapid light, it has a rapid onset and offset of action, and apart from that, the clearance is also fast. Then another important point is that it has anti-emetic properties, so it actually can actually help to reduce the incidence of post-operative nausea and vomiting in these patients. The thiopental could also be used at a dose of 4 to 6 milligram per kg. Midazolam could also be used. This one is actually better in that it's safe and effective for induction, even in patients with severe aortic stenosis. Then etomidate at a dose of 0.35 to 0.45 milligram per kg can actually be a good choice in cardiac patients, as there's minimal changes in heart rate, mean arterial blood pressure. It's more cardiostable. But the only drawback about etomidate is the adrenal suppression that it causes. Then the muscle relaxation for these patients, the main aim of muscle relaxation is to prevent high intraluminal intrathoracic pressure during the laparoscopy. Then the muscle relaxation now, after the induction, the patient will be intubated depending on the kind of patient. If it's someone that is obese, we do rapid, they will be securely using rapid sequence induction. Then if it's someone that is not a full stomach patient, if it's a full stomach patient, they will be securely using rapid sequence induction. But if it's someone that is not a full stomach patient, the patient will be intubated. Then the main aim of muscle relaxation is to provide a good is to prevent high intraluminal intrathoracic pressure and also to give better surgical operating conditions. The muscle relaxation decreases intra-abdominal pressure to the same level. The muscle relaxation decreases intra-abdominal pressure, same level required for abdominal distension. It also gives a quieter surgical field and also gives a better exposure. For intubation, sodium metronym can be used at 1 to 2 milligram per kg. Then for maintenance of neuromuscular blockade, non-depolarizing neuromuscular blockers, the choice is dependent on the patient that is coming for surgery. A patient that have cardiovascular disease, vecuronium could actually be an agent of choice because it's cardiostable and is given at a dose of 0.04 to 0.05 milligram per kg. Atracorium could also be used, rocuronium too could also be used in this patient. Even pancuronium could also be used. It depends on the patient that is being anesthetized. Then for maintenance of hypnosis, inhalational agents like you could maintain hypnosis using propofol based TIVA or even using inhalational agents like sevoflurane, isoflurane, and also these agents they blunt the hemodynamic response to the pneumoperitoneum. Ideally, isoflurane at 1 to 1.5% mark can also be used to maintain inhalational hypnosis in these patients. The nitrous oxide causes nausea and vomiting, and I've already talked about this. Then once the depth of hypnosis is achieved, the use of vasoactive agents like esmolol and labetalol can also be used to control the hypertension that might occur intraoperatively. During induction, pneumoperitoneum controlled ventilation is adjusted, and this is adjusted to maintain the end-tidal carbon dioxide at 35 millimeters of mercury. In patients that have chronic obstructive pulmonary disease or bullous emphysema, there is an increase in the respiratory rate rather than tidal volume. This is to avoid alveolar inflation and decrease the risk of pneumothorax in these patients. For the monitoring under anesthesia, there are mechanical monitors and clinical monitors. For the mechanical monitors, blood pressure monitoring can be done. The non-invasive blood pressure or the invasive blood pressure monitoring can be done. Invasive blood pressure monitoring is indicated in very long surgeries and in hemodynamically unstable patients because it will pick bit by bit the blood pressure. It gives real-time values of the blood pressure. Then ECG tracing. ECG is also a very good monitoring modality with AC segment tracing. This is actually to identify myocardial ischemia early enough intraoperatively. Then pulse oximetry can also be done. Then capnography can also be done. The end-tidal CO2 stabilizes after 15 to 30 minutes of insufflation. Then if the end-tidal CO2 increases after 30 minutes, you want to suspect that the patient might be having subcutaneous emphysema and pneumothorax. Then mechanical monitors like nerve stimulators to monitor the depth of neuromuscular blockade or paralysis can be done. Then also minute volume and peak airway pressures can also be monitored to prevent the risk of barotrauma. Temperature can also be monitored in these patients as part of the routine monitoring. Serial ABG can also be done to monitor the partial pressure of carbon dioxide in these patients and detect acidosis and hypercapnia on time. Then for the clinical monitors, the skin can be monitored for the color, tubal, capillary refill, and venous engorgement in dependent regions. Then the cornea and conjunctiva should also be monitored for edema, especially when positioning someone head down. As there's an increase, you could have an increase intraocular pressure and corneal edema in these patients. The upper chest wall should be monitored for subcutaneous emphysema when there's abnormal neck swelling or chest swellings with crepitus. Then the pulse should also be checked for volume and rhythm, and urine output should also be monitored, as oliguria could also be one of the complications of raised intra-abdominal pressure. For reversal, the reversal should be done after a smooth and compatible dislocation and hemoperitoneum. And also, we should do a smooth reversal in that bulking might increase the intra-abdominal pressure and worsen the respiratory mechanisms in these patients. And bulking can also increase the risk of pneumothorax and gas dissection. So anything that we try to avoid bulking in these patients. Then for reversal, neostigmine can be given as 0.05 milligram per kg, and glycopyrrolate should also be given to antagonize the antimuscarinic effect of neostigmine. After signs of adequate reversal, patient is extubated and shifted to the post-anesthesia care unit. There are complications from this surgery. The complications could arise from injury from the surgical instrument at the trachea. You could have bowel or viscous perforation. You could also have arrhythmias from the hypercapnia. You could also have congestive cardiac failure. You could have gas embolism in these patients. It could be pneumothorax and hemoperitoneum. You could have the patient could have subcutaneous emphysema and also gastric aspiration. The patient could also have cardiac complications like myocardial infarctions, pulmonary edema, basically from pulmonary hypertension, ventricular fibrillation, and a complete block. The next option of general anesthesia with spontaneous ventilation. It's not actually ideal. It's restricted for short laparoscopic procedures and is also recommended in healthy young adults. The procedures performed under this general anesthesia with spontaneous ventilation should be performed using very low intra-abdominal pressures. Regional anesthesia, there's a place for regional anesthesia, but it's not recommended because of you cannot control the ventilation and that the pneumoperitoneum can be very uncomfortable for the patient. Another reason is that the pneumoperitoneum, the diaphragmatic irritation might also not be covered by the regional block. Then epidural with head down tilt can actually be done for pelvic diagnostic procedures. What is limiting regional is also the fact that it requires extensive blockade, which we know regional will also cause hypotension. So combining it with the already existing effects of pneumoperitoneum on the cardiovascular system, the effects will be synergistic and worsen the whole clinical scenario for the patient. Then the only advantage of regional is that there's excellent post-op analgesia, and there's also lower incidence of post-operative nausea and vomiting because of we are not using opioids intravenously for the patient. Then there's also a role for local anesthesia and laparoscopic surgeries. Laparoscopic hernia repair and some gynecological procedures like laparoscopic sterilization can be performed under local anesthesia, but it's not actually very comfortable. Some patients will not be able to relax, and the abdominal wall will not be able to relax the abdominal wall because of discomfort. So these patients might still require deeper sedation or conversion to general anesthesia. So the post-operative management, the pain will usually be maximal during the first 2 hours of the procedure. Post-operative shoulder tip pain is common, and it may be reduced if the surgeon expels much gas from the peritoneal cavity as possible. For post-operative management, the best is using multimodal analgesia, which combines the use of regional anesthetic techniques like local infusion of the port sites, we could also do GA with epidural analgesia for intraoperative and even post-operative pain management. Even transversus abdominal spleen block can also be used in addition to NSAIDs and opioids to manage the pain post-operatively. Then all patients should also, after laparoscopic surgery, should receive supplemental oxygen. This helps to mitigate the effects of pneumoperitoneum on the respiratory function. Then alveolar recruitment techniques such as short-term CPAP or high-flow oxygen delivery systems may also be used. In conclusion, preoperative evaluation of cardiopulmonary status is very important in patients coming for laparoscopic surgeries. Slow insufflation with intra-abdominal pressure of 12 to 14 meters of mercury is ideal. The positioning also has some effects on various systems. Then intraoperative monitoring should also be done in these patients. Then the patient should also be aware of the intraoperative complications, and the anesthesiologist should also be aware and be able to manage them. Then the proportion of surgical cases performed laparoscopically will continue to increase, and the anesthetist must safely manage the specific physiological alterations and challenges that laparoscopy presents. Thank you.
Thank you so much, Dr. Bridget Bassi, for this very erudite presentation. I think we can show some appreciation. Please use your emojis, give a clap, give a this. Thank you so much for the presentation. Very much appreciated. Like I said, we will take our questions and comments. So if you have any questions or comments, you can leave it in the chat box or you can put up your electronic hand. In the meantime, I'll just give a quick summary of some of the things we discussed. So in the past 30 or 40 minutes, Dr. Bridget Bassi has given us an overview of anesthesia for laparoscopic surgeries from the history to the indications, we talked about the history of laparoscopic surgery or keyhole surgery, the procedures amenable to laparoscopic surgery. We discussed some of the advantages and some of the concerns. We discussed the concepts and the mechanics behind intra-abdominal pressures. We then discussed the options, the anesthetic options available for laparoscopic surgery. We then did a deep dive into the anesthetic management of patients coming from laparoscopic surgeries, starting from the pre-op review, the investigations, and then the anesthetic management proper, discussing the general anesthesia with endotracheal intubation and muscle relaxation, the various elements of it, and all we should understand in it. All in all, thank you so much for the presentation, and we are looking out for topics, for questions, comments, or any points anyone would like to clarify. We also want to acknowledge the presence. So please, if you have any questions or comments, just leave it in the chat box or raise your hand and you'll be acknowledged. As we're doing that, want to acknowledge the presence of some of our very esteemed teachers. Dr. Aderonke Adeshion is here. Thank you so much, ma, for being here. I think Prof. Mwaso is here too. Thank you so much, ma, for being here. Always a pleasure to have you on here. Dr. Yakubu Hamisu is here. Thank you so much, sir, for being here. A pleasure to have you on here. Dr. Raphael Taiwo Osele is here. Thank you so much, Chief, for being here. We appreciate you. Thank you for your time. So we'll pause now for questions and comments, or if any of our teachers or trainers have something to say, we'll be very happy to listen. Okay, seeing some comments. Yes, the discussion, the recording of the presentation will be uploaded to the NSA YouTube. So if you've not subscribed to the official NSA YouTube account, please do that. I think we'll share a link both in the general group and in the residence group at the end of this. The recording for this webinar will be uploaded to the NSA YouTube account. Okay. Okay, thank you for the presentation. I think most of our comments are just appreciations to the presenters. Thank you for the presentation. Thank you for the presentation. Okay, doesn't seem we have too many questions. Okay, Chief, sorry, I didn't see your hand, sir. Dr. Adesina wants to speak. Chief, ma, you have the floor, ma. Thank you, ma.
Thank you very much. Can you hear me?
Loud and clear, ma.
Yes. So I want to thank the presenter and the NSA for this webinar. A very important one as the practice for laparoscopic surgery is expanding in Nigeria. So I just wanted to highlight that I know that most times we intubate the patients. For this patient, we do an endotracheal intubation for these cases. However, there's an expansion of the use of second and third generation supraglottic airway in laparoscopic surgeries. So it's good for us to consider those things with some caution. And the caution is your patient, you must know the status of your patient, stratify well. For example, obese patients or patients with ab initio increased intra-abdominal pressure might not be suitable, except you have a device that has pressure monitoring, airway pressure monitoring capacity. So the use of this second and third generation devices have really expanded, and it's something, and studies have shown that there's less, excuse me, there's less airway complications, sore throat, and patient satisfaction is actually better with those devices. So you need to think about the patient factors and then the duration of the surgery and other things that might predispose the patient, particularly to aspiration. So if those things are there, you want to then use your traditional endotracheal tubes. Thank you.
Thank you so much, ma. Really, really appreciate that important comment. And I'm very certain that a lot of us have jotted down a few things and are learning a lot. Thank you so much, ma, for that comment. Okay, so as we wind down our presentation, like I mentioned, the recording for presentation will be made available for anyone who wants to review it. And we are grateful for the NSA for regularly supporting us to have these webinars and discussions. I would like to again thank the leadership of the NSA, especially the president-elect, Professor Quinet Kalu, who is the leader of the Educational Committee, and the president himself, Professor Al-Hassan Dati Mohammed, who is the president of the NSA. I would also use this opportunity to remind us or to announce or to mention that the OGM, the Ordinary General Meeting of the NSA, has been announced is holding next week, Monday, which is the 27th of April, and it will be holding virtually via Zoom. So the link will be shared as is customary, and we encourage everyone to join in and put hands together as we deliberate, decide, and drive the future of anesthesia practice in Nigeria. In the absence of other comments, and so that we can keep to our time, we want to again thank the presenter for an excellent presentation. Thank you so much. You did well, and I think the concepts were well received, and I'm sure that everyone has learned something new today. We also thank all our teachers and trainers who regularly join us on these sessions. We really, really appreciate the support. We appreciate your presence, your comments, and all the information that you give us. We are grateful, and we know that this is an indispensable part of our training. We are grateful to the NSA, like we said, and we would look forward to seeing everyone at the OGM, which is holding next week, Monday, which is 6 days from now. So please make it a date as we continue to support and grow with the Nigerian Society of Anesthetists. So without further ado, thank you all for coming. And We will, for the residents, we'll continue our discussion on the residents group. For everyone else, thank you so much for coming. We appreciate your presence. And this is a good evening from us. So good evening and have a very good evening ahead. Thank you all and good night.